Hello? Okay. Okay, can you call me back? I'm really busy now. Any way you can call me back in a couple hours? Yeah, please call me back. Thank you. Hello, Prashan, are you there?
Hello, how are you?
How you doing? I don't see your camera on.
Give me 1 second. I'll turn that on. Can you see me now?
Not yet.
Hmm.
There you go. Okay, I see you. Is there anything? I'm John Bennett. Is there anything in your webcast you want to go over? You got any videos or anything you're unsure
Uh,
of?
No, no videos, but I can just attempt to share my PowerPoint just so that we can see that it
Yeah.
displays
Then
correctly.
we'll take you off it so we can introduce you correctly. But just,
Perfect.
yeah, put it on there, make sure you can do it.
See if I can.
We've got 10 minutes, 8 minutes.
Right. Um,
Okay, now presentation mode. Do you know how
Perfect.
to put that on? There you go. Perfect. Perfect.
Excellent.
Okay, yeah,
Okay.
perfect. And you said you have no videos, right?
No videos, no. So it should be
Okay,
pretty.
just get off that PowerPoint and once Ahmed comes in, he'll have be introducing you.
Perfect.
Now, where are you at, sir?
I'm in New York.
New York?
So yeah.
Oh, okay. It's still cold up there. Let's see, what is it now? I keep forgetting I'm in
It's
Florida.
June now. It's pretty warm. Yeah.
We got a lot of New Yorkers down here.
Oh yeah. I think they'll start coming back now for the summer and then head back, I think, in the winter.
Yeah. Yeah, a lot of people come down. I'm from up north too, and I really don't like going back.
I can imagine.
Yeah, no, it's gorgeous here. Hmm. Where you originally from, Prussian?
So I actually grew up in Mumbai. That's where I did my medical school
Oh,
training. And
Mumbai. Yeah, yeah, Dr. Goel.
oh yes, yes,
Yeah, that's his home.
that's
We
right.
televise him a lot, as you probably know.
Yes, I've met him once, but I've interacted with him. And then I came over to the States to do my residency and my PhD.
Yeah, he's a universal name. And Dr. Chandra Pujari also is from Mumbai.
That's right. I worked with him actually for 6 months before I headed to the US, so I know him very well, and he
Well,
was one of
I always liked that guy. He seemed so nice,
absolutely.
a good teacher, dedicated, he's got it all.
No, he's great. He's great.
And we've televised him a couple times on series on pediatric neurosurgery. I'm trying to get him to do another, but I think he feels it's too much. Yeah, here's a panelist, Bill. Hello, Abdel, you there?
coding
There you are. Hello, Abdel, you there?
coding بين
I don't know how
إيه،
good your connection is,
how
Abdel. Can you,
are
can you talk, Abdel? I don't know how good your connection is there. Oop, he fell off. He'll be back. What part of the city in Prussian?
So I'm actually living in Queens right now in Astoria, but I work between the city and Long Island, so I kind of commute between both.
Okay, so you're on the island.
Yeah,
You like the subways?
I do. It was nice. It's nice to not be stuck in traffic, so
They're efficient, aren't they?
they are efficient. Yep.
Boy, without those subways, New York would be terrible. Uh, every time I drive to New York, I get lost. And when you get lost in New York, because if you miss the freeway, you've got to go a long way, turn around, and oh
Oh yeah.
man, you've got to know where you're going. Have you had much experience like that driving around?
Oh, for sure, for sure. It's a long turnaround.
Long turnaround when you miss that cutoff.
Yeah.
One time I missed the cutoff, and it was like I was in a hurry to get a plane going to one of the two. I'm not sure which one I was going to, but I backed up on I was crazy. I backed up on the freeway. I mean, in the breakdown lane, but it was looking back on it, it was crazy. Okay, well, okay. Are you back yet, Abdel?
okay
There you are. Abdel, are you there?
okay let let's start now.
Okay, is Ahmed going to come or are you doing it, Abdel?
Okay,
Abdel, are you there? He's there, but the connection, I think, is not too good.
okay, okay. I hear it.
Hello, Abdel. We can't get your picture. I think don't put your picture on because that takes up bandwidth.
Okay, again. Hello.
Hello?
Hello.
Yes.
Okay, sorry.
Yeah. Okay. Hello, Abdel. Can you hear me? Well, you know, Prashan, I'm going to start, okay? Because Abdel's apparently having problems with the computer. So you ready to start?
Yep, ready to start.
Okay, 10, 9, 10,
Hello.
hold on. 10, 9, 8, 7, 6, 5,
I
4,
can hear
3,
me.
2, 1. Good
Okay,
afternoon
okay,
from Miami Beach. This is Dr. John Bennett
okay,
broadcasting from
okay.
right near here in Miami Beach. We have another in the Yemen Neurosurgery Club webcast, and having tech problems, cannot introduce the regular introducer. So I'd like to introduce Prashan Unikat. He's originally from Mumbai, India. He's now at the Zucker School of Medicine in beautiful New York. And okay, Prashan, please take it away. Thank you.
All right, thank you so much for that introduction. I'm just gonna pull up my slides, and that's great. Hopefully you guys can see them okay.
Perfect.
So my name is Prashin, and I am a chief resident at the Zucker School of Medicine. And one of my major interests has been on investigating neuromodulation strategies, especially for Parkinson's disease, which was the center of my thesis work for my PhD. And I thought I could today provide a general broad overview of where we stand. It's roughly been about 35 years since we had the first introductions of DBS in the modern era by Benabid, initially on the thalamus for Parkinson's disease. And subsequently, there have been a number of trials investigating its use for treatment-resistant depression, with the subgenual cingulate being the most common target in the brain. You know, while we've transitioned with the introduction of DBS away from lesioning procedures, which became the predominant modality, you know, from the 1950s onwards, once the stereotactic technique was introduced by Spiegel and then by Lexell. We've kind of coming back around to lesioning with the introduction of focused ultrasound therapies, which is a non-invasive modality to try to lesion the same targets that we use for deep brain stimulation. You know, a little fun thing that I always like to talk about is that if you take 1987 as the point when Benabid first spoke about DBS in the thalamus for Parkinsonian tremor, and you look to 2025, we have a exponential growth in the number of papers that have been published on deep brain stimulation, with about 21,000 and counting since then, showing how prevalent this modality has become. So before, you know, we can reasonably start talking about the topics, what I like to think about with deep brain stimulation is what generally affects the outcome of the surgery. You know, here is a depiction of a 3D model of the subthalamic nucleus in a standard brain atlas. And one of the first things you think about is patient selection. What do you mean by patient selection? So one of the things that we know is that disease severity matters. The more severe advanced the patient is, they tend to have a much greater benefit from DBS. Their motor symptoms tend to improve far more. And the way we measure this is usually using the UPDRS motor rating scale. However, we've made significant advances in probably the last 5 to 10 years, where we've found imaging modalities such as FDG PET and automated computation of network expression scores, such as the PDRP, to try to assess the disease severity in a more objective manner. So we're not relying on a clinician-based assessment, we're relying on an assessment made based on imaging purely. And then when you take a step back from DBS with, you know, newer treatments being aimed at reversing Parkinson's disease, again, just to highlight, DBS does not change the trajectory of Parkinson's disease. It typically just helps with the motor symptoms. But when you think about investigational treatments like gene therapy or stem cell therapy, you want to try to intervene much earlier in the disease process. So you actually want to intervene even before patients become symptomatic. Now, obviously, you're not going to do an invasive surgery on a patient that doesn't have Parkinson's on the hope that they will. So one of the efforts has been to use these network imaging markers to try to identify patients or high-risk patients, such as those that have REM sleep behavior disorder. And this was a nice paper that was published last year by Tang that showed that tracking the progression of this network expression score, you could predict within 5 years which RBD patients would actually phenoconvert to Parkinson's. Now, that's huge. That potentially opens up the gateway to trial a therapy that might reverse the neurodegeneration with PD. Then we think about preoperative predictors. Is every Parkinson's patient a good candidate for DBS? In general, almost all PD patients have a fairly good response, but it would be really nice if we could predict that beforehand. And since these procedures don't treat Parkinson's, rather just reverse the motor disability that patients have, it would be great to be able to tell a patient beforehand how much benefit they can reasonably expect with the procedure. What was the focus of my dissertation work was the identification of this brain network that we labeled STN StimNet. And what we found with this is that the network could actually predict how much a patient would respond to DBS even before they underwent surgery. And we could do this using either PET imaging or MRI. And so right now, the way we determine if someone is a good candidate is using the levodopa challenge test. They have a good response to levodopa, they become candidates for DBS. Although a lot of studies have shown that its prediction of the outcome is actually very variable. So perhaps StimNet may be a new way, the way we think about identifying patients that would be good candidates. And then obviously you want an accurate diagnosis of Parkinson's. Now, it's roughly been about 200 years since James Parkinson's first described Parkinson's disease in the modern era. But we still rely on Parkinson's disease diagnosis as a clinical diagnosis. We don't have an objective marker to be able to do this in a more appropriate manner. And a neurologist typically takes about 4 years to come to a almost near certain diagnosis of PD. But what if we want to treat these patients earlier so that we reduce the amount of medications they have to take, reduce the disability they face? And so again, using these network biomarkers, you can with very high accuracy start to predict those that have Parkinson's disease versus those that have atypical Parkinson's disease. So why does that matter for DBS? Well, we know DBS doesn't work for atypical Parkinson's disease. Patients with MSA or PSP, they tend to progress much faster. Their disability is different and typically don't tend to have the kind of response that we would expect with DBS. Then, once you have the DBS electrode implanted, it's not a done deal. You actually need to fine tune the electrode. You need to set the stimulation parameters. And we know small changes in stimulation parameters can lead to varying effects. Tremors can reemerge, the rigidity can reemerge. And so you want to fine tune this. Neurologists typically take about a year to actually come to a final consensus on what patients' stimulation parameters would be. Using STN StimNet, we again found that maybe there's a better way. Maybe we can use imaging again to fine tune and select the best parameters. However, this is very preliminary. Some of the fantastic work that has actually come out of the Toronto group has been the use of resting state fMRI, wherein they took 10 PD patients with STN DBS, and they actually found these changes in the brain related to stimulation. And what they found is that just with a 30-minute scan, they could predict the most ideal contact pair that should be used, as well as the amplitude that the patient would use that would typically take the neurologist about a year and a half to come to. Now, this is not something that is, something that we're envisioning. This is something that they've shown in a small cohort and potentially could open up the gateway to giving patients the most appropriate treatment much sooner. And then, they achieved this accuracy with almost 80%, which is quite phenomenal and very exciting. And then let's talk about what, as neurosurgeons is the most important thing to us is the electrode placement, because that's really where we come into the treatment of Parkinson's disease. We know electrode location matters. Electrode deviations as little as 2 millimeters can lead to significantly different effects. Patients may be completely non-responsive versus responsive based on this accuracy. This was shown beautifully by this paper by Dembach in 2019, where taking the subthalamic nucleus, they found that when you have the electrode and the volume of stimulation overlapping with what we call these sweet spots within the STN, which seems to lie between the dorsolateral part of the STN, which is typically associated with motor function, and the associative area, you could predict with almost 30% certainty. You could almost predict 30% of the outcome of the DBS procedure, showing that this matters. And they compared this to other papers that have shown a very similar sweet spot. So where do you put this in the subthalamic nucleus matters. It's a very small structure by itself, roughly about 1 centimeter in length, and so you really want to try to hit the spot pretty accurately. And once you have all these overarching factors coming in unison and being appropriately titrated, you land up with the most appropriate outcome for these patients. And you would significantly reduce the disability. Patients with DBS have as much as greater than 50% decrease in their motor disability. And time and again, studies have shown that it significantly improves quality of life. So you really want to titrate this to the best way you can. So what does the DBS procedure entail? It entails first getting high quality imaging on a patient and selecting your target. That can be the subthalamic nucleus or the globus pallidus interna for PD. Other diseases have other targets. You want to try, in the past, we used these standardized coordinates based on standardized atlases or based on some of the work done with lesioning in the pre-DBS era. However, with the advent of modern MRI, we know that we can actually visualize the targets we want to implant on and be a little bit more accurate. Most often people use a T2 or a T2 flare image. However, even that, delineating the borders of the target areas is not always precise. And there have been some advances. In the last 5-10 years, the Florida group introduced the F-gator sequence on the MRI. And more recently, people have spoken about using quantitative susceptibility imaging to identify these subcortical structures a little bit better. So you're not relying on a coordinate that comes from an atlas. You're relying more on the patient's anatomy and how you can reposition the electrode that is suited to that patient. So just to give you an example, this is a side-by-side comparison of a T2 weighted image on the same patient compared to the F-gator sequence. And when targeting the globus pallidus, one of the challenges is to actually demarcate the separation between the externa and the interna component. And usually seeing that is a little bit hard, as you can see on the left-hand side image. But when you look at the F-gator sequence, you can actually really see the differentiation between the externa and interna. And then if you look at on the right-hand side, you look at QSM imaging. Again, this is the T2 weighted sequence on the same patient. And you can see the right nucleus, you can see the subthalamic nucleus, but the borders get fuzzy, especially in the posterior part of the subthalamic nucleus, which is what we target with DBS. And you can see on QSM, these areas show up really well because the subthalamic nucleus has a very high ion content. F-gator can also be used to really demarcate the different nuclei in the thalamus, which otherwise are almost invisible on T2 imaging. And so, these new techniques have significantly, added into what we call precision medicine, tailoring your surgery to the patient. And then, we have higher field strengths. When DBS came out, you'd be lucky to get an MRI on a patient. We then had more frequent use of 1.5 Tesla MRIs. Routinely in the US now, 3 Tesla MRIs are available everywhere, and typically would be used for almost every patient undergoing DBS. And maybe in the last 5 years, people have spoken about using 7 Tesla imaging. Now, I've been fortunate enough to have my brain scanned on multiple MRI scanners. And so I'm going to show you a little image of side-by-side comparison of what my subthalamic nucleus looks like on a 7 Tesla magnet, which is shown on the left-hand side. And you can see the boundaries of the STN so beautifully demarcated. There's no ambiguity. And when you compare that to my scan down on 3 Tesla MRI, you can see how, there is some degradation in the signal, which makes accurate targeting a little bit harder. Whether these actually translate to meaningful improvements in patient outcomes is yet to be seen, but at least objectively, it makes the, targeting a lot more simpler. And then, the reason why we target these subcortical structures is because they kind of act like a funnel where information from, the cortex kind of funnels through them and then dissipates to the rest of the body. And when you can place an electrode in these small structures, you can modulate or change the effects on, very large cortical areas, such as the primary motor cortex, the supplementary motor area. With diffusion imaging, you can do that more accurately. You can use tractography to try to delineate exactly what areas of the brain you want to modify. This is very routinely used in patients for essential tremor or Parkinson's disease tremor. This is an image of, from our center where we used the tracking of the dentatorubral-thalamic tract, where you can see on the left-hand side, to kind of find the sweet spot in the VIM, which is the target for focused ultrasound therapy. The same target's used even for DBS. And you can see that, our lesion was created precisely where the DRTT traverses the VIM. And again, what the VIM is typically not visible on a standard MRI sequence. And so when you can use this tractography, it kind of makes the surgery a little bit simpler. And then what I think has been one of the most exciting papers I've read in the last a few years has been the work coming out of Boston and from Berlin, where they actually found that the subthalamic nucleus connects to, multiple cortical areas. And based on this connectivity pattern, you could actually titrate your DBS to be symptom specific. So on the left-hand side, they found the projections that go to the primary motor cortex and the cerebellum typically help with tremor control. The projections that go to the SMA and the motor cortex can help with bradykinesia and rigidity, and as well as axial symptoms. So it's conceivable using a technique like this, you could actually place your electrode in that part of the STN where the connectivity is highest to the area that is important to the patient. I mean, you have patients that have Parkinson's with almost minimal tremor. Maybe targeting, those fibers that go to the M1 or the cerebellum may not be useful to that patient, and they might not get the absolute benefit that they require. What about advances in surgical guidance and intraoperative imaging? So the way we do it at our center is very routine for most places. We use the frame-based technique. We use the Lexel Vantage frame, which is one of the newer versions of the Lexel frame that have come out. We have the patients awake, and we typically confirm the electrode placement using microelectrode recording. The idea is to try to find the areas in the STN that have, beta band peaks, which is the electrophysiological marker of PD. And then we also do further testing using macro stimulation in the OR. So as the patients are awake, we stimulate onto the electrode that we think is going to be the final implantation site to confirm that patients have no side effects and have the best treatment response. And finally, we obviously confirm, the electrode location using intraoperative CT. We typically use the O-arm. Centers have described using robot assistance, using the ROSA robot. We have that at our center, but we typically don't use that for DBS. We typically use that more for stereo EEG placement for epilepsy monitoring. And then, while, have had limited experience with it, there is a system that allows you to directly target these structures using MRI, which is a company called ClearPoint that makes a system that allows you to have the patient in an MRI scanner while doing the surgery. You can directly target the structures rather than use a coordinate or that can have some inaccuracies. So let's talk about advances in DBS technology. We spoke about imaging, we spoke about getting the electrodes in the right spot, but DBS technology has advanced since 1987. We now have the ability to use directional DBS. So typically a DBS electrode in the STN has about 4 contacts, and you can choose pairs of contacts that you want for monopolar or bipolar stimulation. But more recently, there's been the availability of directional DBS, wherein the second and third contact is typically segmented. So you can actually steer the current away from structures that you don't want the current to go into that cause side effects. So for example, if you see patients with very good response, but having capsular side effects with current spreading into the internal capsule, you can actually use these segmented electrodes to steer the current away from that and primarily divert it to the STN. I have to note that it does not compensate for grossly misplaced electrodes. You still need that accuracy. All it does is that if you're kind of close to where, a structure that you want to be, it can allow you to compensate for that. And then, all the hype right now is about adaptive DBS. right now we use chronic stimulation. Once the stimulator is on, it's always on, and it's always on at a fixed current. But what if you can adapt the current based on the patient's symptoms? Right now, the Medtronic has a system called the Percept PC that has this capability that can actually use technology called BrainSense and can find these beta peaks in patients and can actually titrate the stimulation based on when the beta peaks tend to be more exaggerated. Some fantastic work coming out of UCSF has gone one step further. It's a little bit challenging to find these beta peaks when stimulation is on because it creates an artifact. And they actually have strip electrodes simultaneously placed on the motor cortex to actually use that as a feedback for the stimulation. And they recently published their work in Nature Medicine, showing the experience from 4 patients, showing that it is an extremely promising tool. So, the way I started my thinking into functional neurosurgery was, we have the most information from Parkinson's disease because it's the disease we've treated the most. But what are the lessons that we can learn in depression, which still to this date is not standard of care and is considered experimental and research? So, why have the 2 big clinical trials in depression, DBS, failed? What are the factors? Could it be that we're not targeting the structures precisely? Just like in PD, we know the STN and the GPI are great targets. We don't quite know what the best place to put the electrodes are in depression. And what kind of imaging should we use for that? Is depression really one disease, or is it many disorders? And do some patients respond because they have a certain disease state that is conducive to DBS? And how do you really measure depression? So most clinical trials will usually use these physician-reported or self-reported scales, such as the Hamilton Depression Scale or the MADRS scale. And these are just asking patients symptoms of depression. Can we more accurately measure it using brain imaging? And then again, is adaptive DBS most appropriate? Depression is not a one state. All patients have exaggerated depression and then the depression goes away and then they get it back. And so maybe we need to titrate stimulation based on that. I think, one of the major advances came from this paper in 2017 that found that patients with subgenual cingulate DBS, when the electrode was within the junction of these 4 white matter tracts, which is the cingulate bundle, the forceps minor, the uncinate fasciculus, and the frontostriatal fibers, their response rate almost reached 80%, which was significantly improved from the original 40 to 50% that was reported in larger studies. So we know white matter tractography can be beneficial even in this. So connectomics is useful. There was a very recent paper in 2024 that actually showed using precision MRI, that they found that the frontostriatal salience network is almost 2-fold increased in patients with depression. What was impressive is that they found children, when scanned with this and having this feature, it was also predictive of them having depression in adolescence. So we're finally getting to a stage where we can maybe start to image and measure depression in a more quantitative manner. And then there was this excellent paper that came out in Nature in 2023 that used spectral discriminate components using the BrainSense technology in the cingulate to try to measure what are the features that predict patients' depression and does it correlate with their symptomology. And you can see on that graph on the top that as the patient's depression seemed to improve with DBS, this marker also started to go down. And what was really beautiful that they showed in this paper is that they had this one proof of principle patient who was initially a responder, but then had a sudden relapse of the depression. And you can see that the marker, which is in the red line, actually starts to go up almost a few weeks before they actually had the relapse of the depression. So maybe this patient could have benefited from increasing the DBS stimulation or maybe changing the stimulation parameters. But we're finally getting to a stage where we can quantify what depression is and how do we treat that. And there have been many targets that have been tried for depression. The subgenual cingulate, the most common, the ventral striatum being one of them, the ventral capsule being the other one. And then more recently, work coming out of Freiburg, as well as one of my mentors when he was at UT Houston and now at Northwell, has been the use of a white matter tract called the medial forebrain bundle. And basically, the medial forebrain bundle is this white matter tract that is thought to be implicated in the reward circuits. So one of the things that patients with depression have is they have a they have something called anhedonia. That means they're not able to experience pleasure. So can we actually stimulate the reward networks to try to improve the depression? Can that be a feasible target? And you can see that patients tend to have a pretty robust response with MFP-DBS. They have an almost relative improvement of 80% from baseline, with 8 out of the 9 patients that I have in this cohort that I'm currently studying showing a greater than 50% reduction in their depression symptoms. And about 5 out of 9 patients being classified as remission, wherein the depression scores are less than 8, essentially meaning that they're almost nearing what would be normalcy. The MFP is this actually came about through serendipity. It came about by work by Professor Conan and Freiberg, who actually found that when PD patients had electrodes placed a little bit too anterior mistakenly, the electrodes landed up in the area that was close to the ventral tegmental area. And these patients actually became manic after stimulation. And he after kind of a series of experiments and tractography studies, he found that it was because the stimulation was within the medial forebrain bundle that these patients had this effect. And subsequently, this has led to clinical trials both in Germany and open label trials in the US as well. And some of the work that we've been trying to do is try to understand how does MFP-DBS work? We know how STN-DBS works. We know how the GPI-DBS works. We know about the indirect pathway. But if you see, this is preliminary data with a manuscript in preparation. You see that when you turn patients on with MFP-DBS using resting state fMRI, we see changes in brain connectivity within areas that we know are implicated in depression: the OFC, the subgenual cingulate, the nucleus accumbens. And all of this kind of leads way to why MFP-DBS is so significant, is because stimulation of this area has connectivity through multiple nodes that are implicated in depression. And so, I thought I could end this talk by kind of highlighting where we stand. It's been an extremely exciting time in the last 20 years. Technological advances, as we spoke about, in electrode design, imaging modalities, and even implantation guidance has gone up significantly. We can, with good certainty, walk out of the operating room knowing that we are in a relatively good spot with our electrodes. I think if someone is really looking to get into research and trying to think about how to better this treatment, I think identifying biomarkers of disease states are probably the best bet. We're trying to find ways to use adaptive or closed loop DBS, and I think that's where most of the research is heading. There have been a lot of non-invasive techniques such as focused ultrasound lesioning that have really brought about the era of lesioning back in vogue. And then there are techniques that you kind of start to read about that are non-invasive stimulation techniques, such as low-intensity focused ultrasound using piezoelectric nanoparticles and something called temporal interference stimulation that allows you to non-invasively stimulate very precise, deep structures in the brain. And perhaps the future is not deep brain stimulation where we have to have patients undergo surgery with electrodes. Maybe the future is using some of these techniques to try to help patients. And I think that's where, the research is headed. So with that, I think I'll end my talk. Thank you so much for letting me speak, and I'm happy to take any questions if there's time.
Okay, Ahmed, can you take over, Ahmed?
I'm working around, so I cannot participate with you because there is a noise beside me.
Go ahead, Ahmed. Can you moderate, or Abdel?
Okay. Thank you very much, Dr. Rashin. We are honored to organize with you. I have a common question.
Yep.
Un accent.
Hey, from Afghanistan. Okay, welcome.
Hello, salaam alaikum.
Very good. You have a question or a comment, Ahmed? Can you introduce yourself, please?
Okay, salam alaikum. Eid
Okay.
Mubarak. Thank you. Thank you very much for great webinar. It was very wonderful. Thank you, Professor John.
Thank you. Hey, Abdel?
Okay.
Hello, can I just say something over here?
Sure.
Well, just a minute. Okay. Screen. Uh, today, Professor Ghazi has passed away to the another world. So we wish him, merciful and paradise. So actually, I have no words to express my condolences for the neurosurgery field and for his family. Actually, so thank you so much.
Okay. How can
Was
a
third news.
artificial intelligence and machine learning models contribute to the personalization of data-based therapy selection?
That's a fantastic question. I think, the future is really with artificial intelligence. To give you just a couple of snippets is, I think the selection of stimulation parameters is probably going to be AI guided, as kind of somewhat alluded through that paper from the Toronto group using imaging. It's because, electrodes are becoming more and more complex. So if you have directional electrodes, you have almost 9 or 10 contacts that you can select, and then different stimulation parameters. How do you reasonably do that in a humanistic way by testing all of them? So I think AI can be a good tool to do that. And there's already actually commercial technology available in Europe and coming to the United States, where there are artificial intelligence ways to find the most appropriate place to put the electrodes in. And so maybe that may be another way to do it. And I think eventually adaptive DBS will probably be guided by AI. I think it'll be able to fine tune the stimulation based on the patient's symptoms as it measures. That I think is just beyond the capability of humans doing it, again and again. So I think that's probably where AI will probably contribute the most.
Okay. Question two. What is the scientific basis and clinical evidence for the use uh, psychedelic assisted therapies such as psilocybin in severe depressive disorder?
Oh, that's another fantastic question. We can probably have a whole webinar on that. It's a very exciting topic, but I think one of the modalities has been of these therapies is usually through synaptic plasticity, and the idea that it actually kind of opens up functional connectivity in the brain in ways that you typically wouldn't get without them. And sometimes treatments like those and even ketamine can have profound effects even after a single dose. It's not completely known how they work, but I think the idea is really through neuroplasticity to kind of rewire the brain away from these pathological states that cause depression or anhedonia.
Mm. Okay. Question three. What is the correct role and future potential of deep brain stimulation uh, refractory depression, and what are the ethical consideration surrounding its use?
Absolutely. I think, the biggest concern lies with the fact that we still don't have a clinical trial showing evidence that DBS for depression works. We've seen it work very well in very selected patients and in open label trials, but it's still, out there, whether it, how much of efficacy it has. So I think that's where we kind of stand with that. Right now, because it's very much in the research domain, DBS is typically reserved for patients that have what we call treatment-resistant depression, wherein they failed, 2 to 3 antidepressant medications, and more so, they've had some, potentially had some response to electroconvulsive therapy, or TMS, which is transcranial magnetic stimulation, but are now starting to either not get the same response that they used to, or the fact that they have to get it too frequently. You could probably switch to DBS where they kind of are not tied to going to the clinic every few weeks to kind of get that treatment again. But I think eventually the role will be for patients that have significant depression that just is not controlled with medications, because that leads to a significant decrease in quality of life and patient satisfaction.
Okay. Uh, uh, Thank you very much, Dr. Brashin. Her presentation is fantastic and wonderful. We are honored to organize with you.
Thank you so much for the invitation. It was my pleasure to present to everyone, and I'm glad to.
Okay, Prashan, I just want to run one thing by you. Okay, we're starting a new website called globalneurosurgery.com, and we want to utilize American neurosurgeons like you who come from countries like India, because I'm sure you're interested in educating the neurosurgery community in India. And if you see, I want to basically divide the world up into languages. One of them is in English. Okay, so when you do a broadcast in America, that's perfect for India on the weekend. If you Saturday or Sunday, it goes to India, and we'll be able to promote it in India, so you can share your knowledge of what you've learned in the States with India, and just basically do the same webcast. So we'll keep in touch with that. And if you're interested, just let me know. Okay, I'll leave my email.
Absolutely. I would love to be involved with that.
Very good. Okay, Ahmed or Abdel, do you want to close out, please?
Okay.
You want to finish, please?
I would
Okay.
like just to say sorry for this appearance, but I want to just say thank you for the doctor for joining us and accepting our invitation, and thank you, John, for making this webinar happen. So I'm super appreciative for that, and I want to just tell others there will be a very soon webinar in the coming few days with an Arab neurosurgeon. So that will be very interesting. Thank you so much. I'm sorry for this noising beside me.
Okay, good night, everybody.
Okay.
Or good day, everybody.
Okay. Goodbye.
Bye-bye.